Hello, everybody. Welcome to today's session. My name is Renee Godette. I'm GE Healthcare's Global Education Manager for ABUS, Automated Breast Ultrasound. Before we get started today, let's go ahead and I'd like to review the controls for GoToWebinar. You should see in the upper right-hand corner of your screen your control panel. There's the audio controls. You come in either on your computer audio or phone audio. If you have any questions, please chat those into the chat box, text those into the question box, and we will be able to support any questions that you have throughout the broadcast today. We are honored to have Professor Arabal present for us today. He's amazing. I met him as a peer educator for GE's physician training program. Also, Dr. Arabal is one of the awardees of GE ABUS's Call for Proposals for Research. He's starting a research program on automated breast ultrasound and DBT. Very excited about that. Dr. Arabal is also an experienced breast imaging radiologist from the University of Acibadem, and he's the co-founder of the breast imaging department there. So we're very excited and honored to have him with us today. So without further ado, I'll go ahead and introduce Dr. Arabal to the presentation. Thank you.
Hi, thank you, Renee. Hello, everyone. I'll be presenting today ABUS session, how I use it, where I use it, because it started with the screening setting, but I use it in different settings as well. So objectives of my presentation is there will be a general overview about screening with ABUS, understanding the value of ABUS in screening setting, understanding the potential of ABUS in clinical setting, interactive case studies. We all know that mammography is the best tool for screening of breast cancer and reduces the mortality, but it has some limitation as women under age of 50 with denser breasts has the limitation is about the similar density of the cancer with the glandular tissue. So the lesions can be obscured by this glandular tissue. So BI-RADS has classified the breast density into 4 categories, A, B, C, D, and C and D are denser breasts where these lesions can be obscured. And according to BI-RADS, half of the patients are C or D breasts. And in our daily routine, it's around 40–45% in my clinic. So the sensitivity for A and B breasts is very high, but for C and D it's around 40%. And the odds for interval cancers is 18-fold higher in extremely dense breasts, which is type D breast, compared to fatty breast, which is type A breast. But mammography has some problems. It has false positives and false negatives. False positive recalls causes increased radiation exposure, patient anxiety, cost, and unnecessary biopsies, where false negatives cause harm due to interval cancers and missed cancers. So what is the solution? Apart from breast MRI, the more easier way to this problem is to use digital breast tomosynthesis or ultrasound. I'll just give some brief about the tomosynthesis. It has better lesion detection and characterization, clear imaging of these slides from tomosynthetic images eliminates the pseudo lesions which may overlap with the glandular tissue, and also it provides more accurate findings. This is a dense breast with density C, or we can call it between C and D, and there you cannot see any mass inside, but this tomosynthetic image shows a mass with spicullated borders almost 2 centimeters in diameter. When you look at the 2D mammogram, you see nothing there. In this case, the lesion is smaller, but you can see the speculated small lesion on tomosynthesis images, but you cannot see it on 2Ds. Or in this case, there is something here, but you cannot see clearly, but on the tomosynthesis images, you can see the mass with the speculated borders. And in this case, it looks like a speculated lesion, but there is nothing on the tomosynthesis images. So it decreases the recall rate, increases the specificity and sensitivity of mammogram, but it has some problems, disadvantages. It increases the reporting time of the radiologist, and there is also a learning time. It may have a higher cost depending on the countries. It may increase the mean glandular dose because in some settings, they both do the 2Ds and 3Ds together. However, supplemental handheld ultrasound screening is a well-known adjunct to mammography in dense breasts. It has low-cost modality, no ionizing radiation when compared to tomosynthesis. It's widely available and easy to access, well tolerated by the patients, but it is operator dependent. It may be used by sonographers, or radiologists, or some other doctors. It's time consuming for the one, if that is the one who is the radiologist doing the ultrasound. It has high number of false positive cases that causes, all of them causes heavy workload for the radiologist. So a solution may be the ABUS, because with the ABUS, you do not perform the ultrasound by yourself, and you don't have to depend on the sonographer's skill because you have the volume images in hand. When we look at the supplemental screening studies with ABUS, the highest number screened in the studies is the one with the Brem and colleagues, and their additional screen detected cancer rate was 1.9 per 1,000 women. And the other studies, the main studies, showed higher numbers, but they have lower screened women when compared to the Brem and colleagues study. When we compare this ABUS study with the other handheld ultrasound screening studies, the numbers are quite comparable. With ABUS, it was 1.9 per 1,000, but with the J-START study from Japan, it's 1.8 per 1,000. And there is another study from Italy with 22,000 women, it's 1.85. So the numbers are comparable with handheld ultrasound supplemental screening studies. When we look at the coronal views, that we are not used to these coronal views, ABUS gives us this option. You can, from starting from the nipple, you can see the texture while going down towards the thoracic wall, and we know that there is the lobar anatomy of the breast, and you can just follow easily the ducts and the lobar anatomy, the fibroglandular and fatty tissue texture. And it helps a lot to see a speculated mass or a stellar pattern inside this texture, like in this case. And you can also have transverse images, which we are very familiar of. In this case, there is a mass here on the transverse image and on the coronal image. It is easier for the eye to detect the black hole inside this texture of fibroglandular and fatty tissue texture. This is another case with a very small lesion. There is a dilated duct here, but it may be difficult to detect on transverse images. But here on the coronal image, it's easy for the eye to detect the black architectural distortion here inside the texture of the fatty and fibroglandular tissue texture. So coronal images, although we are not familiar with coronal images on ultrasound, helps us in detecting these lesions easily. In this case, you can easily detect the stellar pattern or the retraction phenomenon, which shows the malignant feature of the lesion. This satellite margin had high specificity as 98%. So why automated? As I told you before, there are problems with handheld ultrasound. It's performer dependent. If it's not you, it's not the radiologist who is performing the ultrasound, then there may be a performer interpreter dissociation. It is operator dependent. It takes the time of the radiologist if that is the radiologist who is performing the ultrasound. Standardization is very hard, and it's not reproducible. You lose the images. You only have the pictures taken from a live examination. On the other hand, the automated has the whole breast volume image. It has standardized projections. You can image in different places like coronals and sagittals or transverse images. Batch reading is possible for screening cases, so you may do the batch screening the day after the examination, and double reading also possible. And also there may be some softwares like CAD or AI. It's possible to also use them in the future, I guess. This is our study for the examination time. We examined the 1,400 consecutive patients who underwent for both breast screenings, and we only took patients who had 3 positions, 3 projections from each breast. And we started this study after 15 days after the implementation of the system. The average time for examination was 13 minutes for the sonographers. And when you look at the first 10 examinations and compare it to the last 10 examinations, there is huge difference between the examination time. So there is a learning curve for the sonographer as well. And this is another study that we performed with a senior radiologist and a junior radiologist, compared their time for reading the ABUS studies. And it showed that with an experienced radiologist, it's around 3.5 minutes, and with the inexperienced one, it's 4.5 minutes in average. So there is a learning time for this as well. When you compare these examination time and reading time with the literature, it's in the literature is 15-30 minutes for the examination and 5 to 10 minutes for the reading time. This is a very small case. Here we see the retraction phenomenon, this architectural distortion with the satellite stellar pattern. It's like a black star here with speculations. It's easy to detect on coronal views, but it's a very small lesion. It can be easily missed on transverse images or on ultrasound, handheld ultrasound image. And this is a very small lesion. Here we again easily you can detect here the lesion with its stellar pattern. This is the handheld ultrasound image, and here you see the transverse image, which are comparable. So the transverse images almost are identical with the handheld ultrasound images. And this is a Doppler image of the same lesion and elastography. Of course, handheld ultrasound gives us more information like Doppler or elastography. This is another very small case. You can see a black star here with speculations, very large speculations. And the transverse image shows the lesion, which is taller than white. And you can see the edema, the echogenicity is higher here because of the edema around the lesion. You can see the edema around. So when you compare with the handheld image, it's almost identical. So it's not that the resolution of handheld ultrasound is better, but it gives almost identical information with the handheld ultrasound. There is another, there is intramammarian lymph node close to the lesion, which we were not able to find with the handheld ultrasound at first look. And the Doppler image showed this vascularity, but the elastography didn't show too much stiffness. So it was an invasive cancer. These are two different cases. Because of the nipple and areola, there might be some shadowing behind the areola, and it may be difficult to see the lesions behind the areola or nipple. So the sonographer must be skilled about spreading the lotion evenly on the areola and nipple. And so I will show you some cases which are just retroareolar or behind the nipple. Here, it looks like a lesion. This one also looks like a speculated mass. Here, this is the transverse image. You see the shadowing, that the lotion was not spread well. You see shadowing starts from the skin line. So it's an artifact, but it looks like a lesion here on the coronal images. So if you see something on the coronal images, you have to go to the transverse images to understand if it's a shadow, artifact, or a real lesion. And this one is a real cancer. Another case here, you can see this is the a surgical incision line, and here you can see that it starts from the skin line. And this is another case, cancer case. This is a male patient with a palpable mass lump on the right nipple, right breast, and it's just behind the areola nipple complex, and you can easily see the detailed findings of the lesion, and the images are comparable with the handheld ultrasound. A case with 53-year-old woman. She has a negative screening mammogram, but on ultrasound, she has a black lesion here, but it doesn't have the stellar pattern or a retractional phenomenon, and it looks like a cyst here. You see there is no architectural distortion or retraction or speculation, and the margins are smooth. And this is the ultrasound, handheld ultrasound image of the same lesion. It is an oil cyst. 48-year-old woman. This is the mammogram. Here you see some calcifications and And here there is some asymmetry here and here with the calcifications. On tomosynthesis, you can easily see the speculations. This is the slice. And here is the lesion on ABUS. It's a stellar pattern with retraction phenomenon with the speculations. And this is the lesion on transverse image, which the image is quite comparable with the handheld ultrasound. And this is the MRI finding, which was found to be an invasive lobular cancer. A 38-year-old woman, she had an ultrasound examination without mammogram. Here you can see just close to the nipples, some ducts are dilated. When you look at the transverse images, you can see the dilated duct and hyperechogenic dots inside the duct, which are calcifications. Here you can see the calcifications better on this transverse image and on the coronal image as well. And this is the mammogram. Here you not very clear on mammogram. And this is the handheld ultrasound image, almost identical with the transverse ABUS image that we have seen the dilated duct first with the ABUS and the calcifications inside it. It was a DCIS. So we use it mostly after a positive mammogram screening. If we see something on a mammogram, then I don't do any more handheld ultrasound. I prefer to do the ABUS first because it gives me the overview of both breasts and it gives me the overview of the finding that I've seen on the mammogram. This is a 56-year-old woman. She had a screening mammogram. She has a history of previous excision of a fibroadenoma in the right breast 5 years ago. This is the left breast. Right breast was normal. Here you see two lesions, and this is the ABUS view, the coronal view of the two lesions together. They have both stellar pattern, a black star with speculations, and this is the lesion on. This is the upper lesion and this is the lower lesion. Both of them look suspicious. And this is the handheld ultrasound, almost identical image, and the lower lesion. Both of them were invasive cancer foci. A 42-year-old woman, she had a screening mammogram and ultrasound together. Her mammogram showed an architectural distortion, but her spot view was normal. She had her mammogram in a different center, different imaging unit. So she came for a second opinion to my office. Here you see this architectural distortion on the left breast, close to the axilla. And here on the spot view, you don't see it anymore. But when I check the coronal, when I check the CC view, I have seen the architectural distortion and I thought that the distortion was real. And I asked her to have ABUS. She had already a handheld ultrasound examination by a breast radiologist in the other center, and her examination was normal. So this is the ABUS finding of the patient. Here you see the stellar pattern with retraction phenomenon, and the black dot inside. It's not very obvious, but you can easily detect the stellar pattern. And here there is some shadowing, but you cannot delineate the lesion very well. And this is the MRI of the patient. So after a second look handheld ultrasound, I found the lesion. And this is the Doppler image. It was a stiff lesion. on elastogram and we did biopsy. It was an invasive cancer, Automated A, a very slow growing cancer. 44-year-old woman, she had a screening mammogram which showed pleomorphic regional calcifications. It's evident that you see the calcifications both on 2Ds and tomosynthetic views. And I had the ABUS view of the patient, and you see the calcifications very well on coronal images on the upper outer quadrant. Here, this is the transverse view of the ABUS. You can see the dilated ducts and the calcifications inside in different views from ABUS. And this is the handheld ultrasound. Almost the images are identical. And when I can see it on ultrasound, I prefer to do the biopsy with 14 gauge cut needle instead of doing a vacuum biopsy. And I will always check the specimen and the mammogram, and you see the calcifications were retrieved with 14 gauge needle. And it was a DCIS. She had a 9 millimeter of invasive focus after the operation, after the breast conserving surgery. 47-year-old woman, she had a screening mammogram. Here you can easily see the retraction of the skin, and on here you can easily see the lesion on tomosynthesis. And this is the ultrasound image of the lesion, and this is the coronal view on ABUS. So this is an evident cancer, but I prefer to do the ABUS in these cases to map the lesion well, because she's going under neoadjuvant chemotherapy, and it will help us to map the lesion on coronal views. It's an invasive cancer. And this is the MRI finding. The MRI feature of the lesion looks very similar to the coronal findings, which you cannot easily delineate. You can see the lesion very well on 2D transverse images here, but you cannot see the 3D spatial position of the lesion well on 2D images. But the coronal image can give you this mapping well. 42-year-old woman, she had a screening mammogram. Almost nothing on CC views, and she has a slight architectural distortion here on tomosynthesis, here again. And the lesion here is just behind the nipple. It's again a very large tumor. So the mapping is very good with the coronal images. And this is the 2D handheld ultrasound. This lady, she wanted to have a baby and to have an IVF therapy, but before the IVF therapy, she had a mammogram for screening, and there were some calcifications behind the left nipple. Here you can see it better. So I prefer to do ABUS imaging for calcifications, and you can see two different lesions here. Let's go back. Here you see the dilated ducts, and here you see a small black stellar lesion. So she had two different lesions, and they were far from the nipple. So the calcifications were close to the nipple, but the dilation of the duct and this satellite stellar lesion was far from the nipple. Here again, here that is the stellar lesion here, and this is the dilated ducts on handheld ultrasound on the 12 o'clock region. So I had the MRI of the same patient. This is the area, the region, the calcifications were on mammograms, but this is the contrast enhancement, which was far from the nipple. these were the dilated ducts that we have seen on ABUS and on ultrasound as well. So I did the same thing, 14 gauge biopsy, and it was a DCIS. 50-year-old woman, screening mammogram shows a mass on the right upper inner quadrant. This is a type A breast, and you can easily find, but on type A breast, it's sometimes very difficult to find the lesions because of fatty tissue. Ultrasound cannot show you the hypoechoic. You may not detect very well the hypoechoic lesion inside the hypoechoic fatty tissue. But on coronal view, you can easily see that stellar pattern with the spiculations. And this is the small lesion inside the fatty tissue, which is not easy to find on 2D handheld ultrasound. A 46-year-old woman screening mammogram showed she had on CCs you don't see anything, but on MLO there is a mass here, and the mass looks like the margins are well defined here, and this is the coronal image that you do not see here the stellar pattern. You do not see the retraction phenomenon, and it's a kind of lobulated margin, but you don't have the spiculations. And this is the transverse image, and this is the handheld image, which showed to be a fibroadenoma. 43-year-old woman with multiple breast cysts. You can easily see a lot of masses in both breasts of the same density with well-defined margins. But on tomosynthesis, there's something here which looks like a spiculated mass here. And this is the finding on coronal image. And this is the transverse image of the ABUS. And this is the handheld ultrasound image, identical findings. And this is the MRI of the lesion, which was a luminal B-type invasive cancer. So I use it a lot of times for the diagnostic workup of patients who has palpable lumps or who has findings on mammograms. Even in cases when we see the calcifications, I first prefer to do the ABUS to find out if I can see the calcifications or the dilated ducts that preserve those calcifications. 48-year-old woman, she has a lump on the right breast. Here you can see the lump on the inner part. And this is the tomosynthesis images that you can see easily the spiculated mass. It's a very large mass, like 2-3 centimeters. Here is you can see it on coronal images, and here on the transverse image you can easily see it, and the images are comparable with the handheld ultrasound findings. This was the only mass I've seen on handheld ultrasound. In this case I performed the handheld ultrasound myself, but apart from this lesion here, I have seen some small lesions on ABUS here, and we can just find them here. We will see it right now. You see here, some small lesions. I thought it was a multifocal, and when we had the MRI, she had more than I've seen either on ABUS. But I was not able to find them on handheld ultrasound. So there are a lot of studies with ABUS. These studies in general show that the final most important factors associated with lesion detectability are the mean diameter of the lesion, surrounding tissue changes, shape of the mass, and significant differences between malignant and benign masses are retraction phenomenon that we see particularly on coronal images. Hyperechoic green again can be seen on coronal images. There is fair total agreement for solid lesions, malignant, benign differentiation margins and pathological diagnosis, and moderate overall agreement on mass size, shape, posterior features, orientation, and Biret's category. Smaller lesions and lesions with lower final assessment category were less frequently detected on ABUS. That is also my experience, that you do not see a lot of benign lesions or benign changes on ABUS. I think that is a good thing, because most of these benign changes is, I have to say, sometimes they are difficult to interpret. Lesion detection was reliable, 92%, only when mean lesion diameter was over 1.2 centimeters. I think this is too large. I think it's also reliable below 1 centimeter in my experience. Here you see the classifications. Again, I'll case-big classification, because classification is one of the major difficulties that you meet with mammograms. And this is the MRI. You see that MRI of the lesion shows a wider lesion than the calcification area. And here is the ABUS finding, that you can easily see the dilated ducts behind the nipple on the lower part on 6 o'clock, and the calcifications inside it. Here, the handheld ultrasound has similar images findings. And so as I told you, it's a 14 gauge cut biopsy that I checked. I've seen the calcifications, and she had a DCIS. So why for diagnostic imaging I do ABUS? Because it helps me to evaluate both breasts in a very easier way without consuming my time, and enables a shorter focused handheld ultrasound examination. I have to focus only the findings, only the important findings that I've seen on ABUS. And mapping of the disease is very easy. So for B3 lesions to follow up, mapping is easy. Now I only follow up the lesions with ABUS. It's very easy to compare the priors with the original examination. It is a very good tool to guide the surgeon, because surgeon can see the coronal image that they are used to see on operation room, in the operation room. And also you can use it in neoadjuvant chemotherapy monitoring, and you can also use it in second look ultrasound localization after a positive MRI finding. So follow-up of breast cancer patients are easy, because you can compare with the priors. Here you see the lesion, stellar pattern, and here you see the operation bed, and it was local recurrence. For second look ultrasound, this is a 40-year-old high-risk woman. She had a small lesion here. It looks like a small fibroadenoma, but I was not sure. It was very small. It was not, I couldn't find it on handheld ultrasound, but it was very easy to find on coronal views. And you see that it does not have a stellar pattern. It is a very well, the margins look very well, and it looks like oval-shaped fibroadenoma. We did the biopsy, however, it was a fibroadenoma. ABUS examination can be evaluated after MRI finding, and it is easy to correlate with the MRI findings. They have both with handheld ultrasound, they have both similar performance. ABUS can replace second look handheld ultrasound. It reduces the diagnostic time, minimizes recall rate and stress, enables a better focused handheld ultrasound after finding something on ABUS. This is a case where we have two different lesions on the inner part of the right breast. This is like 3 o'clock. This is like 4 o'clock, 5 o'clock. When I showed this to my surgeon, he couldn't understand the location of the lesions, and he said, are they apart from each other? And when I showed him this image, and I said, This is the upper lesion, this is the lower lesion. It's very easy for him to understand how to make the surgery. It was a papilloma with atypia. This is the upper lesion, and this is the lower lesion. And this is the upper lesion on handheld ultrasound and lower lesion on handheld ultrasound. A 72-year-old woman, she has left breast cancer. This was a very interesting finding. We have seen, you can easily see the ribs when you go further to posterior with the coronal images, and inside in between the ribs, you can see the internal mammalian lymph node here. It was a lymph node metastasis in this patient. And also we can see the first level 1 of the axilla. This was a case with breast cancer, and you can see the axillary lymph node metastasis. Of course, I do the axillary handheld ultrasound for deeper lesions like level 2, level 3, but you can on screening or on some diagnostic purpose, you can see the level 1 with ABUS. With neoadjuvant chemotherapy, it's also handy. You can use it for mapping. You can see the lesion here. But when you see the transverse images, you cannot understand the shape of the lesion, but this image gives you the shape better. Another case with a very large lesion before neoadjuvant chemo, and here you can see the location of the lesion very well, but on handheld ultrasound it's too large to see it in one view. These are the other foci of the lesion, but you can see them all together here on coronal images. And after neoadjuvant chemotherapy, also you can see some of the lesions well. So my ABUS experience is the operator learning curve is 2 to 3 months. Average examination time for us is 13 minutes for 3 projections for each breast. And average reading time is 3-4 minutes, 4 minutes we can say. Enables re-examination of the volume data, because sometimes something you find afterwards, or you do an MRI, you find something, you can go back and check your ABUS volume data and find the lesion there. It may cause recalls, but it gives me more time to do other things. And batch reading and double reading is possible. Also, you can add some the add-on of some new technology like AI is possible. Take-home messages is ABUS can complement mammography very well for screening and so for some diagnostic purposes, as I told you. ABUS can be the first choice in problem-solving ultrasound. So you can do it first and see the lesion well, and then you can have a very short, focused handheld ultrasound examination. And you can also map and monitor the patients, breast cancer patients. ABUS is a reliable, reproducible tool in screening, reliable in diagnostic evaluation of breast lesions to analyze lesion in 3 dimensions, and coronal planes improve the diagnostic accuracy. Readers should be familiar with ABUS images, particularly with the coronal images. There is a learning curve and there is a specific training which is required. ABUS has high reproducibility in description of lesion location, distance from the nipple, lesion size. It has a potential use in follow-up benign lesions and monitoring neoadjuvant chemotherapy patients, and it can be also used second look ultrasound after a positive MRI examination. So thank you very much. This is my team for the ABUS. Thank you for listening to me. Thank you.
Thank you, Dr. Arbal. That was a great presentation. I loved your cases. They're just beautiful, beautiful, beautiful images and great clinical information. We have about 10 minutes for question and answer. So if you can go ahead and chat in on the question box your questions, type in your questions, and we'll address those. While you're doing that, I'm going to take a couple of quick polls in the audience. and see if we can ask you some questions here. Give me 1 second. Okay, let's see. I'm going to launch this first question for you. We'll give you a few minutes for the answers to come in. Okay, so it looks like our audience is about half and half if that's their first time hearing about ABUS technology. And remember to go ahead and chat in any questions you have. And let me ask if anybody here is an ABUS user. We have anybody out there that's using automated breast ultrasound? I know there's whole, this would be automated, not handheld, but automated. Got about 60% of you voted. And anybody else out there want to chime in? Okay, so we have a few users out there, which is great. You might have some questions that are a little bit different, but a lot of you, this is a new modality. And we'll go ahead and ask some questions here. My first question that I have for you, Dr. Arbel, is what is the value of ABUS for a center that only has is only currently using diagnostic ultrasound?
I think there's a lot of value, as I told you, told in my presentation. I use it as the diagnostic modality as the first modality after a positive mammogram or a positive MRI imaging, because it gives me the information about both breasts at the same time, and I can also find the lesion where it is located. Sometimes it's not easy to find the lesion on handheld ultrasound, or you have also the volume data of the patient, and you can go back if you find something else in the future. You can go back and check your images as well. So it helps a lot. I always take ABUS first for diagnostic purposes.
So always ABUS.
Yeah, even the patient has a palpable, very large lesion, I have the ABUS first.
Great. Question for you, my question as a follow-up to that is, how much of your ABUS in your practice is used for screening ultrasound versus diagnostic?
Well, we have a very large screening population, so 90% of my cases are screening. So 90% of my ABUS is screening, but I do have all my diagnostic ultrasound images first taken by ABUS. So every patient who is going to have a diagnostic ultrasound goes under ABUS examination, but not every screening patient, because in some patients I don't do any more screening for ABUS, particularly for implant patients. I do not prefer. You can have, there is no problem, there is no harm, you have good images, but I prefer to do handheld.
Okay, great. When you're using, there's another question coming in. When you're using ABUS diagnostically after a mammo, are you doing a complete ABUS exam or just one view to cover the area seen on mammo?
No, complete both breasts. Even you, for example, if you see something on the right breast, I do the both breasts, right and left, at least 3 projections or 4 projections if the breast is large.
Yeah. And I'd imagine then you get even more information, just not on that one lesion.
Yes, I
Yeah.
want to have the overview of the both breasts, because in one case we had very recent case. She had a right lump, and so she had a cancer on the mammogram. But on the left breast we had another lesion, very small one, but it was cancer as well. So you have to do both.
Yeah, very important.
Yeah.
Another question: being such a new technology, is it a problem to have adequate clinical training and experience?
For ABUS?
Yes, for
Sorry.
ABUS.
Oh, yes, sure. Because, well, I spent the first 3 months of my, after my installment of the ABUS, I spent my time in doing ABUS and the handheld ultrasound in every patient to understand what was happening, to get used to it, and to be more experienced. I strongly recommend everyone to do for 3 months to do them both.
Okay, great. Yeah, this is another question, but it kind of chimes in with that one. It's very challenging to differentiate artifacts, and I don't know if this is a new user experienced, but from real lesions, whether they're small and the non-spiculated, non-star shaped. Do you have any tips there? So maybe this as a user.
I'm not sure I got your question well.
It's a challenge to differentiate. How do you differentiate artifacts from real lesions?
Artifacts, yeah. There are two main artifacts you can meet. One of them is you don't have evenly spread lotion, so you have artifacts, shadows coming from the skin line, so it's easy. So if you can follow that hypoechogenic city or hypoechogenic lesion up to the skin, you will see that it goes to the skin line. So it's an artifact, it's an air bubble artifact. The second one comes from very small ones, because in between the Cooper ligaments, you can have some small artifacts. It looks like a mass, like a malignant mass. But after some time, after 3-4 months, you get used to it.
Yeah, and I'm going to make a plug here to Dr. Arabal. I'll make a plug. You are a peer educator for GE, and we have a very robust training program for physicians where we go through multiple cases when you start reading. And we also have a very robust program for training technologists. So they spend time with the applications for 3 days for all the breasts, because there is a learning curve for sure, as you mentioned. But we definitely want to support that through our training programs that are available to all of our customers and new users.
Yeah, it's a very efficient program. Yes, I had it also myself, and it helped me a lot to understand what was happening. Yeah.
Another question here, Professor, could you please describe the qualities or features of a black hole to look out for the lesion?
Yeah, the black hole is the stellar pattern or the retraction phenomenon. When you see a black hole, it may be on coronal images. Most of the black holes are the artifacts of the hypoechogenic shadowing that comes from the Cooper ligaments. So when you see a black hole, you can just, these artifacts are mostly in triangular shape. But the real case, small 5, 6, I have detected even 4-millimeter cancer. They are very small, but they are like real stars. They have the speculations all around, and they are round. And what you have to do, go on the black hole and click on it, and you will have the transverse image that passes inside that black hole, and then you can understand if it's a hypoechogenic shadowing from a Cooper ligament or a real lesion. So transverse image helps you to understand, but coronal image helps you to detect at the first glance.
Yeah, I agree. I think that's a great. The coronal is the new image for breast imaging to get used to looking at. but you just go over that area and then you'll be able to see in your transverse image, the correlate to the coronal. So it makes it easy when you're learning, right?
Yeah.
That's great.
Yep.
And then on that question there was about color, I just want to reiterate that the automated breast ultrasound in Vinia system is 2D. So if you want to use color or some of the other modes, then that's when you go to your handheld targeted ultrasound.
Yeah, and it's a very short examination, only 2-3 minutes. It takes my time for 2-3 minutes. Just find the lesion.
Is it faster than after the automated to do your handheld?
Yeah, because you know where it is. I just put my hand there and I find it every time. And even it's a very small lesion, I just find it and I just check for elastography, Doppler, and I don't have to check whole breast because I know that there's not anything else in the other part of the breast.
That's
so
true.
It's a very short examination.
Yeah, that's good. And you get the correlates. Do you use the correlates from the automated ultrasound then to know exactly where you're going to go on your handheld?
Yeah, it helps a lot.
That's great. Another question is for measurements of nodules. We've always had to do handheld ultrasound.
Yeah, I don't do any more handhelds particularly for monitoring patients for B3 lesions. For example, you've seen a fibroadenoma-like lesion and you say follow up for 6 months. When she comes for a 6-month follow-up, I just measure it on ABUS and I just let her go if it's the same. Yeah.
And then another question on that, as I know you cannot do biopsy, means that you need to shift again to a handheld ultrasound?
Yeah, sure.
Right. And then there was a question about elastography. Again, those are more targeted applications that you would use that's not on the automated system. It's a little bit different if you want to address that.
Yeah.
Okay, great. Well, we're coming up to time. I'm going to make myself presenter again. One last question for everybody. I also wanted to mention that Jamie Wong and the emails, she's your local representative. So if you have questions that you would like to have answered, email her. She can get back to you right away. I'm going to go ahead and launch a last question here too. Would you consider acquiring this new modality? Okay. Well, I like this answer. That's great. And you have Dr. Arabal is an expert, and we really appreciate your time and sharing all of your knowledge. We are recording this webinar, so we'll be able to share that with everyone later. And if you have any more questions, if I didn't get your question answered, we had quite a few come in. We'll answer those questions and get back to you. So thank you again so much for attending today and or tonight. And thank you again.
Thank you very much. Thank you.
Thanks, Dr. Arabal. Bye-bye.
Thank you. Bye. Bye.